Hello, everybody, and welcome to this discussion on deep vein thrombosis. My name is Pathophysiology. I'm an internal medicine resident physician. And like I said, we're going to talk about DVT here, a common pathology that we can see. And we really care about this because when it goes unnoticed or when it goes unchecked, that's when you get emboli to the lungs, and that could have devastating consequences. So listen into the video, and I hope this helps. All right, everyone. So let's talk about deep vein thrombosis, or DVT. Starting out with the epidemiology. So we have an incidence of about 100 per 100,000 person years for DVTs. And interestingly, there's about a 20 to 30, 35% rate of recurrence of venous thromboembolism in the first 10 years following an initial event. That really shows us here why it's even more important than you might think initially, right? Because once you get one, you're at a much higher risk of getting another. And why do we really care about that the most is in lower extremity DVTs, which are the most common location for deep vein thromboses, up to 50% of these will actually embolize the lungs and give you a PE, or a pulmonary embolism. The lower risk would be below the knee DVTs. These have a much lower risk of embolization. Upper extremity DVTs embolize the lungs about 10% or less of the time. And finally, about 20% of cancer patients are going to develop a DVT at some point during their course. So it really makes you think that we really should be looking out for this in those populations especially. Now, this is highly dependent on the stage and the type of malignancy, but nevertheless, we need to be watching our oncology patients for this complication. Talking about the pathophysiology, the important thing to remember with the pathophys is Virchow's triad. So for Virchow's triad, it is stasis, meaning blood stasis, hypercoagulability, and endothelial damage. So we'll start on the left here with stasis. So stasis is, as it sounds, anything that's going to slow down the venous blood flow, or arterial, but we're talking about vein thrombus here. So these are things like heart failure, right? Because if your heart isn't pumping as strong or as well as it should, the blood is flowing at a slower rate generally. Anatomy, meaning some people, for whatever reason, maybe it's normal, maybe it's an abnormal variant, their veins might have a twist or turn that will slow down the flow in the vein. Immobility, of course, so living a more sedentary lifestyle, and that's always like when we're taught in med school, if you're on a long plane ride, transatlantic or something, you're at a higher risk of DVT, right? Because you're immobile for whatever it is, 12, 13, 14 hours. There was an interesting study actually not too long ago. A Japanese study showed that every 2 hours of watching TV per day is associated with a 40% increase of fatal PE. So I don't know, I think that's probably hard to corroborate, but the point is there, right? That the more immobile, the more sedentary lifestyle we live, the higher the risk of thrombosis. May-Thurner syndrome we'll talk a little bit about later, but this is similar to anatomy. It's an anatomical condition that will slow down the flow. And then venous insufficiency, right? So looking at hypercoagulability, so these are things like malignancy, so that's what relates to our cancer patients that we talked about in the previous slide. Obesity will cause a hypercoagulable state. Smoking, infection, sepsis, DIC, autoimmune disorders, estrogens, including birth control pills, hormone therapy, factor V Leiden, the prothrombin gene mutation, protein CNS deficiency, and APLS. So these last four are the ones we classically think of whenever you hear of a hypercoagulable workup. Usually we're thinking of things like this, but all of these in this box can contribute to a hypercoagulable state. So don't just think about the inherited or the acquired genetic sort of causes. Think about the lifestyle-related things as well. And finally, endothelial damage, right? Because remember, when endothelial cells are damaged and broken up, they release tissue factor, so that sets off our coagulation cascade. You have platelet adhesion after that type of thing. So with endothelial damage, self-explanatory, right? So if you've had surgery, trauma, or lines like PICC lines, midlines, even IVs, central lines, all sorts of things will cause endothelial damage. So about the evaluation and the workup, we'll start with the history and the physical exam. So first things first, have they had a past clot? Remember we said, if you've had one clot, you're at about 20 to 35% risk of having another during your lifetime. Knowing they've had one in the past is really going to help you think about whether they have one now or in the future. Like we said, any sort of immobility, plane rides, extended sedentary periods. So maybe if they've had a long hospitalization recently, whenever you're in the hospital, patients are in the bed all day, every day, essentially. Also, plane rides, if they really don't get out much for whatever reason, maybe they're elderly, they can't move very well, that sort of thing. Trauma, so like we said, that's endothelial damage would be where that contributes. Then we look at the physical exam. We're talking about DVTs, and the most common place for DVTs is the lower extremity. So look at the legs, right? More often than not, the DVT will at least start in the calf and usually extend up. So look at their legs, look at their calves. And if you look at this picture right here, what are you seeing? The right calf, the right leg is clearly more edematous and swollen than the left, right? And you can even see some redness here. The foot, especially, you can see the difference in color, right? So that would be unilateral swelling. And then, of course, palpate it. See if it's tender to palpation, especially in the calf area. Palpate behind the leg on the calf and ask the patient if it hurts, or look at their facial expressions to see if they're wincing. And then also you can measure the circumference, right? So if it's hard to tell, you think maybe one's bigger than the other, but it's hard to tell. A lot of times the clinic or the hospital will have one of those paper tape measures, and you just measure the circumference of each leg. And if one is 2-3 centimeters or more bigger than the other, okay, that might be making us think, okay, this could be a clot. Palpation, right? We talked about that with the painful calf and palpation. And remember, pulses should be intact, right? This is deep vein thrombosis. We're not talking about arterial. If somebody comes in like this, and maybe it's a little more dusky color, and you try to feel for a posterior tibial or a dorsalis pedis pulse, and you can't feel anything, that's an emergency, right? Because that means maybe they have an arterial occlusion or clot, and that person can develop an ischemic limb very quickly. So that's an absolute emergency. And finally, there's a physical exam sign called the Holman sign. So that's when you take the foot and you dorsiflex it up and see if it hurts, right? Because the idea behind that is when you dorsiflex the foot, it's going to stretch out those calf muscles, applying pressure to the calf veins, which if there's a clot might cause some pain and discomfort. So another thing you can try. One of the biggest decisions you make when you're thinking about if a patient has a clot or not is, do you need to image this? And the answer to that comes down, well, how sure are we and how high risk is this patient for having a clot? Like a lot of areas in medicine, we have a scoring system here, and it's called the Wells score. So I'll say before this, if you have a high degree of certainty, you're very confident that this patient has a clot, they have the physical exam findings, the story lines up, it's totally fair to just go ahead and get the imaging, right? No reason to waste time. This scoring, the Wells score for DVT, is if you're not, there's a lower pretest probability in your head, right? You think it's possible, but I don't think it's as likely, right? So that's when you'd use the scoring system. And you can see there's a bunch of questions here that you can plug in the patient's answers to. So do they have an active cancer? Have they been bedridden? Calf swelling. This is where measuring the calves comes in. Is the leg swollen? Have they had a DVT in the past? So all these things like this, plug it in there. And then it risk stratifies you, right? So if your score is less than or equal to 0, it's low or unlikely. 1 to 2 is moderate. Greater than or equal to 3 is high or likely. And if you're low, so if you're in this category here, or just barely in the moderate and you're still not too convinced, go ahead and get a D-dimer, right? Get a lab test first to try and save that imaging. Because if you don't need the imaging, you don't want to get imaging if you don't need it, just so you're not wasting time and resources, right? So get the D-dimer if it's low or low moderate risk. If it's a high risk, go right to the imaging, right? Because there's a good chance there's a DVT hiding in there. And when we talk about imaging, in DVT, it's compression ultrasound with color Doppler. We'll talk about that now with the compression ultrasound. So when the sonographer does this, what they do is they'll have the patient externally rotate their upper and lower leg, right? So they can have kind of a easy access to the veins. And they'll put the ultrasound and they'll find the veins. And as they go down the leg following the veins, they'll keep compressing. Because if a vein is just blood and has no clot, it should compress quite easily. But if there's a clot, it doesn't compress very well. The other thing they'll do is they'll put on the color Doppler, right? So the color Doppler shows you if blood is actually actively flowing. And so if you see an area where there's color and then it gets cut off or pushed to the side, that could also indicate a clot. So let's look at some images here because I think this can really help understand what this looks like. And if you do POCUS, you can even sometimes get a preliminary POCUS yourself if your patient's in the ED or something like that. All right, so let's look at this image up on the top first. So the sonographer here was nice enough to label things. So we have a right common femoral vein, and they're showing the right greater saph coming off of it here. Here's the artery on the left. And when we look at this, so this is just a very obvious, clear thrombus in the vein, right? So blood on echo or ultrasound is going to be black because fluid. And so when you have a more solid material, it's going to show up with a more hyperechoic look like this. And when we talk about the compression, so here the sonographer is pressing down with the probe and the vein is not collapsing. So we know that this is a thrombus. Look at another one. So another thing is similar to the rule in X-ray, one view is no view, that type of thing. We look on the left, we see the transverse view, and this looks pretty good. It doesn't really look like there's anything in here. Maybe there's a little haziness, but it's very hard to tell. And looking at just this view, you might say no clot, right? But then when we rotate the probe to get the longitudinal view, you can see right here that there's a little bit of clot. And so important to always get a few views. We'll look at this one here, which is actually showing the compression. And so here we have our common femoral vein. As they compress, it's completely compressible, right? There's nothing stopping the vein from completely compressing. You can quiz yourself, what is this in this vessel? So this is going to be the right common femoral artery, and this is the deep branch of that. Something that can look like a venous clot on ultrasound is, what is this up here? Because this kind of looks like a vein with a clot in it. And the answer is that's a lymph node. Lymph nodes are notoriously deceptive and look like clots on ultrasound. But how would you know if it is or is not? Just follow it with your probe, right? If it disappears completely, this whole thing, then you know it's not a vein, right? Because veins are longitudinal, right? They go down the whole leg. So we'll talk about treatment here. Medical management of DVTs, right? So really comes down to, is this a provoked or is this unprovoked? And what that means is, can we figure out what caused it or not? If we can, it's provoked. If we can't figure out what caused it or there's no reason, it's considered unprovoked. So we'll look at provoked first because those can be a little easier to treat and understand. If it's provoked and the thing that provoked it is a temporary risk factor. So let's say, for example, they just had a big operation. They had a hip replacement. A week later, they have a DVT. The surgery itself is the risk factor, and that's what provoked it. Would you really need to give somebody in this situation anticoagulation for the rest of their life? The answer is no, because the surgery was a one-time thing. Once the clot goes away, they don't have that surgery as a risk factor ongoing, so we can stop the AC. So the answer to this, in a provoked with a temporary risk factor, is 3 to 6 months of anticoagulation, sometimes more, but the point is, after 3 to 6 months, repeat the ultrasound, and if the clot is gone, you can discontinue anticoagulation. On the other side of provoked, but the thing that's causing the blood clot or that did cause the blood clot is still there, or it's going to be there for a while. For example, some sort of cancer, malignancy, when they're in the earlier stages of their treatment, so that it's going to be there for a while. This is sometimes where you think of a longer course of anticoagulation, and sometimes up to lifelong. All right, every patient's different, so I don't want you to think lifelong no matter what in this situation, but oftentimes it can be, right? You're just going to tailor that to whatever it is that caused the DVT or that provoked it. If we look on the other side, the unprovoked DVTs, these are always a little tougher to think about treatment, because on one hand, you don't want to put somebody who may otherwise be healthy on a blood thinner for the rest of their life, right? Because that has risks. Putting somebody on an anticoagulant has risks of bleeding, especially in somebody who might be elderly or has bad balance, right? Because if they fall, then they're bleeding in their head, they're bleeding wherever. So we look at the unprovoked DVTs, and we think of these if it's proximal or distal. And proximal means above the knee, distal means below the knee. So we'll talk about if it's an isolated distal unprovoked DVT, meaning they have a clot, you don't know what caused it, but it's only in the calf veins, right? It's below the knee. It does not extend above the knee. And the reason we care about that, as we said in the beginning, the below the knee clots embolize much, much less frequently. And in these situations, you want to initiate anticoagulation generally at least 3 months, sometimes lifelong, depending on the patient, on the specific case and the workup you do. Because if you have an unprovoked, no matter what, you're going to want to do some sort of workup to try and figure out what is underlying that caused this. So at least 3 months, maybe lifelong if you don't even figure out what caused it. But no matter what, if you're going to try and stop the anticoagulation, which could be reasonable at some point, make sure the clot is actually gone before you stop it. And then finally, the unprovoked DVT that is proximal in the lower extremity. This is above the knee. That's lifelong anticoagulation. Above the knee, you have a high risk of embolization, almost 50% risk of a PE from a lower extremity DVT above the knee. So that's a lifelong anticoagulation. And all of this here is regarding lower extremity. This is not talking about upper extremity. So when you come to your anticoagulants, things like the 10A inhibitors, apixaban, rivaroxaban, edoxaban, these are all oral, which is convenient. They have easier dosing. So apixaban, for example, is twice a day. Rivaroxaban is once a day. So they can be very easy for patients to keep up with. Direct thrombin inhibitors, these are things like dabigatran, which is PO. And then there's 2 IV direct thrombin inhibitors, argatroban and bivalirudin. Of course, we have heparin, which is continuous IV, low molecular weight heparin, which is a sub-Q injection twice a day, generally speaking, for treating a clot. And then we have fondaparinux, which is also a sub-Q injection. Last but not least, we don't use it anymore. We hate using it now, but sometimes you just have to for whatever reason. Insurance won't cover something else, but the answer, warfarin, is an oral. And the reason we don't like it is very hard to control. Because these people can have very big swings in their INR, and they can have very large risk of bleeding if they overshoot their INR goal. So what can we do besides medical management? Thrombectomy and stenting is always a consideration. And we really want to think about thrombectomy with or without a stent if the clot is caused by some sort of anatomic variant or compression of the vein. Usually when there's a compression, it could be from a tumor, like in a malignancy. So we have this diagram here. So what happens if you have some sort of tumor? Maybe you have a uterine or ovarian tumor that's sitting in your pelvis and it's pushing against one of the iliac vessels, right? And narrowing the vessel so that it slows the flow down, and then you get a clot, right? It's provoked, first of all, because you have a tumor that's causing stasis and a malignancy that's causing hypercoagulable state. But even if you give this person anticoagulation, the tumor is going to keep pressing and they're still going to have that risk of DVT, right? So the answer could be here, go in with IR, interventional radiology. They can take the clot out and then put a stent to keep that vessel open against the tumor so that the blood can flow back freely without getting stasis. So that could solve the problem. Now remember, they still have cancer, so that's an active risk factor. You might still give them some form of anticoagulation, but a stent and thrombectomy in that situation could also help, right? May Thurner mentioned briefly earlier. What that is an anatomical variant where the right common iliac artery right here presses up against the left common iliac vein, and you end up getting a low flow state through this junction point because it's pressing against the vein, and you can get clots distal from there in the vein. So that's another scenario where stenting and thrombectomy could be helpful. The patient is very symptomatic, which DVTs can be. They can be very painful. You can get a lot of stasis. You can get venous ulcers in the lower extremity. That could be an indication to thrombectomy and or stent. If they can't tolerate anticoagulation, what if you have a patient you want to anticoagulate them for the DVT, but they keep bleeding every time you start their Eliquis or their apixaban? Maybe you have to give them a thrombectomy and then stent the vessel. Venous stasis ulcers, we mentioned. Important thing to remember also is if you're going to put in a stent, typically you'd still need to give that patient DAPT or dual antiplatelet therapy for at least a few weeks to a month, and then maybe even aspirin longer than that, right? So when you're doing a stent, think about it. Is this a patient that actually can take pills, right? Because our antiplatelet medications are pills. and some patients may not be able to. Maybe they have dementia and they can't do anything by mouth, or they're not exactly the most reliable to take a pill every single day, because if they don't, this thing you can have an in-stent thrombosis fairly quick without taking DAPT, especially in the acute phase of after it was placed. The inferior vena cava filter. So when do we put in an IVC filter? Well, the biggest reason here is if they can't tolerate anticoagulation. Now let's look, what is an IVC filter? An IVC filter is exactly what it sounds like. You put a filter in the IVC, the inferior vena cava, and the idea is if this person has a DVT in the leg and a piece chips off and tries to embolize, the filter catches it in the IVC before it goes to the lungs and causes a PE. So if you have a patient and they can't have anticoagulation, or they bleed every time you give it to them, the clot is just going to be there in the legs. You don't want it to go to the lungs, so you can put in a filter. And it's a damage control type of thing. Important thing is, this is not meant to be permanent. A lot of times these filters will go in, the patient will be lost to follow-up, and it never gets taken out, right? This is an external object, so if it's in there long enough, the filter itself will become thrombogenic, right? It's a metal object in the body. And then it can start to dig into kind of the wall of the vein and cause endothelial damage itself. So if it's in there for more than 3-6 months, this can start to cause problems itself. So you really want to make sure you're on top of your patients that get this. They know it really should come out in a few months. And while we said, yes, it reduces the risk of leg clots flicking off and flying into the lungs to cause a PE, it's not 100%, right? So it cuts the risk of a PE from a DVT in about half. So it's by no means 100% prevention. I want to talk about one complication to DVT. That's the post-thrombotic syndrome. This can be really unpleasant for patients, something we should really be mindful of, and it really shows us why DVTs are a big deal too. So 50% of proximal DVTs are going to lead to a post-thrombotic syndrome. What this is 1 to 2 years from the initial presentation of the clot, you start to see the pathophysiologic changes in the vein. So if you imagine here's your normal vein, veins have valves, right? And they help with the forward flow, but they prevent backflow, right? So when you have a clot, you can imagine the clot's pushing up against the walls, could be pushing up against the valves. It's causing these micro trauma to the vein. It's going to cause inflammation to the venous wall, damage the valves, and what you happen is you have these leaky valves that cause backflow, and there's a lot of inflammation in the vein itself. Valves begin to reflux, and these symptoms are especially perpetuated when the patient stands up, because then gravity is coming down, so you have more pressure in those lower extremity veins, and these patients end up feeling pain, the leg gets swollen, and then you get these worsening edema and even venous ulcers down here in the legs. You can see here. So here's an ulcer. Start to get this red, painful leg. Very painful. So this is a very big detriment to the patient's lifestyle. It's painful. They might not be able to be as mobile because of it. So it's something we really need to pay attention to. So I hope you found that to be a helpful discussion on DVT, and stay tuned for a soon to come out video on pulmonary embolism, as these are pretty closely related pathologies.